Okay, so coming up, we have our 5 experts here. And to start us off, we have John Reiling, whose background and experience is in hospital administration. I'll turn this over to John. Many of you may know his experiences at the hospital at West Bend, which really focused on patient safety, and I think truly drove you to a whole new level of appreciation
Screwed me
for
up
it.
in life.
Screwed him up for life. That'll show you. We also have Rob Tannen with us, who is a product designer and human factors expert. So to your question about human factors, there's an opportunity to talk to Rob as well. We have Jonas Schultz, who is also a human factors specialist from Canada, to talk about some of the work that he's been doing in the design of their facilities. Tejas, Gandhi, who you met this morning, who is an management engineering expert that can talk about all the processes that they've used, and Bill Rostenberg, architect extraordinaire, who is a specialist in radiology and provides that link between the clinical perspectives through some of the groups where you're the liaison. So I'm going to turn it over to John the whole time.
Okay, so I have 10 minutes here. The first couple introductory remarks I want to make is that I'm very honored about being here. I have to say that for me to be considered an expert is not true. But this room is full of a lot of people that have really made a difference in the patient safety world, and to be part of this is a very cool thing for me. That's point number one. Point number two is that I was telling Kerm this just a second ago, that when we started on the project for St. Joe's, which was a long time ago now, right, there was no discussion in the field about patient safety and design, right? And it is very cool to be sitting here debating, how do we do this best and what are the things we should include. It's a very cool thing that as an industry we're getting there in terms of the whole issue around it. Now, in that regard, at St. Joe's, I want to make a couple. This is not in my order yet. Okay, so in that regard, at least my personal assessment about what does it mean, what is the purpose of improving safety through design? What is that really about? What's the definition of that? And to me, there's 3 components to it. One is we are trying to use design to get rid of adverse events, right? And that's why I raised the question that, we should be organized in these projects around what are the design features that are going to help get rid of infections? What are the design features that are going to help lower falls? What are the design features that will get rid of medication errors? To look at the error itself, understand why it's caused, and look at how we mitigate that through design. That's number one. Number 2 is a human factors cognitive thing. The reason why all this stuff happens is because people make mistakes in organizations, and we haven't set up the conditions where they're going to more likely be accurate about what they do. So if you look at human factor research and you take something like noise, right? Noise creates more errors. So if you're going to try to create a facility that is going to have less errors in it, therefore less harm to patients in terms of an active failure, you should create the conditions in which people are more likely to do some things accurately. And you can hear it in the discussion here, but the National Learning Lab and a National Advisory Committee studied this, and what they came up with as those latent conditions, and Angeli had a lot of them, is noise reduction, visibility of patients to staff, patients involved with their care, standardization, automate where possible, minimize fatigue, immediate accessibility of information at the point of service, minimize transfers, minimize patient movement, and communication. That they felt that those were the key latent conditions that we should design around. So I would argue that in the guidelines there should be a section on latent conditions, there should be a section on adverse events related to patient safety. Then the third piece, and many people think this may be the most important piece, is the link that facility design has on processes and culture. And most people who have studied this, when I get the experts together to talk about this, is that they think if you're really going to have high levels of patient safety in an organization, that you have to have first and foremost a strong patient safety culture in the organization. Then you have to have strong processes that are focused on safety, and then you have to have facilities, and they're all intertwined. You can hear the discussion today, like you spent a year trying to figure out how are we going to do the work, and then we want the facilities to do it. And facility development is such a wonderful thing because it's such a change agent. It's like a once in a lifetime opportunity to get people to think about how they do work and the culture. And so, for example, at St. Joe's, we spent all this time talking about a controversial issue in the field about how much you standardize something, right? But what was more important from my standpoint is that when people looked at the processes, they said we're standardizing our processes because it lowers error and makes things better outcomes. The 100,000 Lives campaign, the pay-for-performance work done by Premier have all shown that a fundamental of getting those outcomes was standardized process that people adhere to. And what happened at St. Joe's is we created a standardized culture. That people looked at the world about why isn't that standardized? Not, gee, we want a lot of variation because Dr. So-and-so wants to do it this way and the nurse wants to do it this way. People said, whoa, that's not safe, right? It was a very cool thing. And I think that the use of facility development around process management and around culture change, I think, is huge. Okay, the final point that I want to make here, and then I want to talk about the task at hand about these process tools, is that there was an article done by JAMA that I would recommend everyone in this room read. It was done in 2002, and it was an article by Leaps, Berwick, and Bates. And if you know these people, Leaps, Lucian Leap is probably he was the guy that spoke nationally in 1999 that kind of broke the whole patient safety thing. Bates is very well known for his work on medication errors and other safety issues, and Berwick, everyone knows, was president of IHI and now works for the federal government. And there, at this time in 2002, there was, AHRQ had created, Kerm, I think you remember this, AHRQ had created evidence-based medicine document. It was a huge document in which they got all the medical groups together and they said, what is evidence-based, consensus evidence-based medicine? And they came up with this document. It was very cool. But they created JAMA called it a controversial discussion. And the three of them wrote this article called, What Practices Will Most Improve Safety? Evidence-Based Medicine Meets Patient Safety. Everyone hear what I'm saying? Evidence-based medicine meets patient safety. Now I would argue that you could just change the words, evidence-based design meets patient safety. Okay? And the point that they made in this article was that it makes a lot of sense and it's smart, like the work that Eileen is doing on falls, especially if we're put in a document where minimum standards is the case, that you have to have stuff that you could prove to people. But the way that doesn't jive totally with patient safety, the way I say it is it's necessary but not sufficient, is a paragraph that I thought that hit me when I first read this. Aviation safety, for example, was not built on evidence that certain practices reduce the frequency of crashes. It was not built. Instead, it relied on the widespread implementation of hundreds of small changes in procedures, equipment, training, organization, and I would say facilities, that aggregated to the establishment of an incredible, strong safety culture and amazingly effective practices. These changes made sense, were usually based on sound principles, like latent condition management or getting rid of adverse events, were usually based on sound principles, technical theory, or experience, and addressed real-life problems, but few were subjected to controlled experiences. So in other words, you go to aviation and you say, why are you so safe? They say, it's got to be your technology. They say, well, we don't know. We never did studies around this. We never proved something in advance of doing it. We just looked at a circumstance and said, gee, here people are falling out of bed, right? What are the things that we could do to stop them from falling out of bed, right? And they would make up stuff and they would do it, and somehow all this process change and culture change and facility and equipment change got the outcomes that they wanted, right? That's safety. It's risk management is safety. They also made a point in this article to talk about there is one service in hospitals that has high levels of safety, and that's anesthesia, right? And this was interesting enough. The reason they decided to get safety is that they had so many malpractice suits. They were worried about, could they stay in business? And they're almost Six Sigma level of safety now in terms of harming patients. You go to the anesthesiologist and in the profession and say, why are you so safe? You hear trillions of different answers, right? They're safe because they just made up ideas that made sense to them about how to get safety. Right, am I all on time already?
You've got a minute left.
Okay, all right. Okay, so I would recommend that. Now, relative to the point at hand here, there was a list of suggestions made by this National Learning Lab and National Advisory Committee about what do you do in terms of process to really achieving high levels of safety. They said you should do a matrix. This is pre-design, like the year before you start doing the project. FMEA at each stages, patient families involved with the design process, equipment planning from day one, mock-ups from day one, design for the vulnerable patient. That means you kind of design for the worst case, and you're probably going to hit the best case. Articulate a set of principles for measurement and establishment of a checklist for current and future design. Right? That's what they said that we should use in our design processes that will help achieve high levels of safety and quality. Okay? They also gave us a list of adverse events to design around. Right? They gave us a list of I just read them to you, a list of latent conditions to design around. Now there's two of them that I would like to pursue, and our group 5 tomorrow is going to talk about. One is the matrix, and the other one is FMEAs. And the matrix is basically a quality functional deployment exercise for those who have studied, quality management issues. That is really a cool tool that I've had about 6 or 7 institutions in the country do it, and they never not thought it was valuable. And that is, you front end everything. You front end the plant, how to design around adverse events, and all that. And then then when you get into the project, you kind of know how much money you're spending on equipment and technology and plant and what are the key design features you want in the place. It's really a cool tool. We're going to talk about that tomorrow. And the second tool is about doing design FMEAs. There's many people in this room here who I know have experience with process FMEAs. But design FMEA is a little different approach to it. It's looking at the facility and how the facility can screw up the processes and cause harm by its own right. It's a very cool tool that we learned from the automotive profession, and we're going to study that tomorrow and talk about that. So that's it. Sorry, I'm done.
Here. Moving along, Rob Tannen is next.
You guys hear me? Yeah, okay. Real quick, thanks for having me here. I'm sort of an outsider in that I'm not involved in hospital or healthcare design at the facility level. I'm not a clinician, I'm not an engineer. I do product design and product design research, largely in the medical field, not exclusively. and sort of asked to speak about how safety in product design might apply to healthcare and vice versa. I do have a particular interest in evidence-based design. I've actually written about how the principles of evidence-based design could actually be applied to product design, and maybe I'll talk about that as well. But you can see my provocative title there. The idea being, well, you know, we've got this separate, if you look at product design, there's no consolidated body of knowledge. There's no single journal. It's very diverse and varied, and if anything, information is not shared, it's coveted because it's proprietary and competitive. So that's sort of the position I'm starting from. And so I started thinking about designing for healthcare and designing for safety. I thought, well, what are the characteristics that make the healthcare or the hospital environment unique or different? So I started to list some things. Well, one, maybe unlike some other products or systems, it affects virtually everyone. It's a combination of old and new technologies. You've got both preventative care, but you also have to deal with accidents or unpredictable things. Obviously, fatal errors have been talked about. It's also highly regulated. There's the need to have license to practice. There's a need for insurance. There's inspection processes. And when I realized this, I thought to myself, wait a second, I'm not talking about hospitals. I'm talking about cars. Because if you go back to that list and think about all the things I mentioned, needing license, needing insurance, annual inspection, that all applies to the automotive industry as well. Being somewhat cynical, but not entirely. And the reason being that the automobile industry, which was just referred to a minute ago actually as a model, as well as aviation, has a lot of comparable challenges in diversity, in complex systems, in regulation. And if you look at what the automobile industry has done over the last 20 years or so, these are, this is decline in fatalities between 1979 and 2002, so approximately 25 years across various countries. United States are on the left. United States, unfortunately, I guess, has a disproportionately smaller decline in fatalities, but still a decent, I think 16%. Some of the European nations, international nations there had 50% decline, and that might relate to SUVs and other things. But the point is that when, through design, regulation, and education and other techniques, you can make a very measurable, very significant difference in safety and fatalities. So I think that's something to look to. So in the product design world, we use a number of different methods. This is not meant to be completely exhaustive, but you can see we kind of divide the world between qualitative and quantitative, which I'm sure you're all familiar with. But we also divide it between what I call generative and evaluative. So generative being research to generate, come up with ideas, identify problems, and then evaluative to test or validate the potential solutions to those problems. So, for example, as probably has been discussed earlier today, the idea of doing focus groups or observation or interviews to understand current processes, task analysis, building simulations and mock-ups to evaluate those. So that's the kind of methodology we use in product design. More specifically around safety in product design, we can kind of break up the world into three categories or three areas. When you're designing your product, you want to make it safe in these three ways. First, I'm calling intrinsic safety. That term is actually borrowed from mining. In mining, you're underground, there's toxic gases, there's flammable gases. You don't want to bring in a device that's going to cause a spark and blow up the environment. And so you design something that's not going to, through its own design or through its own flaw, cause a problem. You can then generalize that idea to all other products. You don't want to make something so sharp that when you pick it up, you cut yourself. So that's kind of the short-term, immediate, safe design of a product. The second aspect of that is ergonomic safety. So that's not the immediate use, but perhaps the repetitive use or the long-term use. Maybe it doesn't hurt you to use it immediately, but maybe you've been using it for several hours or several months or several years, and you start to get pains or tendinitis or long-term injuries and decrement. And that is one of the areas I focused on in terms of ergonomics. And certainly, I think healthcare professionals can relate to those sorts of issues when we talk about moving patients. And then the last area of safety is usable design. And this isn't necessarily always directly associated with safety like the first two are, but it's about designing a product so that it can't, the likelihood that it's used ineffectively or incorrectly, which might lead to an injury, is minimized. And so that's making things intuitive, making things easy to use, and so on. And so we try to look at all three of these aspects when we're designing a product. I'm going to talk about a couple of examples. First, this is a scalpel used for eye surgery. Obviously, this is not a this is a mocked-up photo. Well, it's actually a real photo, but it's sort of a glamour shot. Normally, when someone's having eye surgery, they're draped, and also they're not wearing eye makeup. That I give away. One important thing I should mention is most of the stuff that I work on is designing for the other side of the house. That is designing for the healthcare providers, the surgeons, the nurses, the technicians, to use things safely on patients as opposed to the patients themselves. For example, home healthcare devices might be designed more for patients directly. And so the goal in this project was to improve the safety for the users. So you've got the surgeons, but you've also got the technicians or the nurses or the assistants who are actually handing over the blade to the surgeon. And we did a lot of field research, observational research in this study that led to the final design, which you can see is a retractable shield that covers the blade when it's not in use. And the interesting thing here was kind of differences in findings with different methodologies. So in doing interviews and doing simulations, we were told and we were shown, this is how I passed the instrument blunt tip first. When we actually observed actual surgeries, we saw the opposite. And so you have to be careful when you're doing mock-ups and simulations because the environment and the context isn't exactly real. And people aren't lying, they just don't realize what they do. Another project, real quickly, is a safety syringe. And this is, again, for healthcare providers to reduce accidental stick injuries or infections. Basically, once the injection is deployed, the user flicks down with the thumb and the shield is deployed over the syringe to protect from sticks. This particular design had 99% success rate when given to novice first-time users. In other words, professionals hadn't seen this device before, were given it, were asked how it would work, and 99% had success in deploying it effectively. And I think that's a really important point, not only because it's obviously a successful product in that sense, but more importantly in this context, that's rarely done in product design. You know, when this projector was designed or when this laptop was designed, it's very unlikely that they went out in the field and studied, you know, are people getting the focus rate 99% of the time, and do we need to fix it? That's not kind of part of the culture as much as it is in medicine and healthcare. And so with that in mind, I kind of reverse my position and say design for healthcare is actually special, not only because of that post-design measurement, but because we're kind of in a unique position where we're pulling the best practices from different industries like product design, like human factors, like aviation, creating a centralized shared body of knowledge and sharing it, perhaps most importantly. Just anecdotally, I have been able to apply some of my background into healthcare facility design. This is a project from a few years ago. Aviation Hospital, which is nearby near Philadelphia, recently redid their outpatient clinic, and so we did spaghetti diagrams. This is actually focused on patient flow as opposed to provider flow. Interesting thing here was they were going from a small, this was the existing layout, they're going from a smaller clinic to a larger one, and one of the things we noticed that they were going to lose was a lot of nonverbal communication. The quarters and the space were so tight that people were bumping into each other, running into each other, getting in each other's way, which is an inconvenience, but it's also a benefit because I know what you're doing, I know if you're, what's going on. And so that was something that we wanted to address in the redesign with the new space. We also looked at, so if that's space, this is time. Each point represents a patient and how long they waited in the waiting room, and then how long on the vertical axis their treatment was. And so we were trying to quantify some pre-design measures on that so we can compare post-design as well. Down to 1 minute. Okay, so I'll wrap up. So really a lot of this shouldn't be news to you, but just giving my perspective. When we're talking about designing for safety, we're not just talking about one aspect, and we're probably not just talking about the three I'm talking about here, but you have to consider the immediate risk, the long-term risk from repetitive use or use over time, and then the misuse risk. There are three kind of ways of looking at it. You've got to look at all the stakeholders, not just the patient, not just the healthcare provider, but everyone who's going to be affected by the product or the system. And then, of course, the importance of measuring both pre and post launch, which is one of the strengths of evidence-based design. And I'll stop there.
Thank you.
My name is Jonas Schultz. I'm a human factors specialist. I work for Alberta Health Services in Canada. And today I'm going to talk about how we've incorporated human factors into the various stages of the design process. So briefly, human factors is the study of how people interact with spaces, equipment, and services. So sometimes we'll have a perfectly designed space that's very easy, efficient, and safe to use, or we can have a poorly designed space that's inefficient and unsafe to use, even with the same providers working in that space. And human factors then provides tools that we can use to evaluate the differences of those spaces. So sometimes when we're designing, in theory, we have good ideas, but in practice, it doesn't necessarily work out the way that we had hoped. So here's a couple over-exaggerated examples of that. And some ways to avoid that is, as we know, to involve patients and to involve staff in the design process in all the different stages. How we involve those people in the design process is evolving over time. So it starts off by showing them drawings and asking how that would fit with their workflow. The challenge here being that for nurses and doctors and healthcare people who aren't architects and can't take a 2D drawing and figure out how much space that actually represents, it's difficult to know if they're going to have enough space to perform those clinical tasks that they're expected to do. So the next stage in the evolution was to create these mock-ups where now I can see how much space I'm actually given and I get more of a better picture of what we'll be working within. The challenge here is that, particularly with new medical procedures, it's difficult to understand what it's going to look like after all of your colleagues get into that space with all of their equipment and all those processes. And it's not until you're embedded into the actual process that you understand these design challenges that you're faced or some of the challenges. And so that's kind of where human factors comes in, is it helps us to better understand that. I'm going to talk about a case study. So we're building this hospital in Calgary, the South Health Campus. In 1 year it will open with 300 beds, and at full build it'll have 750 beds. And the design process, much like all design processes, followed kind of a standard process. But what's a bit different was human factors was embedded into the different design stages. So in 2007, we started by doing observational assessments of existing spaces. And then in 2009, we did simulation-based mock-up evaluations. In 2010, we did usability testing and heuristic evaluation to help with the RFP process and purchasing medical devices for the facility. And we're currently going through testing different medication administration processes through simulation as well, prior to opening the hospital or prior to commissioning. And I'm going to go through these stages in a little more detail. So first, starting with the pre-design work. Here's one of the rooms. This was a medication room that we evaluated. It's in one of the cancer institutes in Edmonton. And what we did is we looked at, through video analysis, how users were using that space. We found that there were 5 medication preparation areas in this medication room. And then what we did through the video analysis was we plotted where all of the interruptions were occurring when they were preparing medications. So each dot indicates the location of an interruption. What we found was that nurses working at preparation space number 3 were more likely to be interrupted than when they were working at any other prep space. And the reason why is the medications we can see in this picture are stored directly above their preparation space, so there's a lot of interruptions to get that shared supply. So one of the design characteristics that came from that was to store the medications in a more shared space that wasn't right above someone's workspace. So then when it came to schematic design, like other facilities, we built mock-up evaluations in a temporary structure that was built for that purpose. So we had 4 mock-ups that we evaluated: an acute care unit, an emergency exam room, an outpatient exam room, and an ICU patient room. And I'm going to focus a bit more on the ICU one and acknowledge my co-authors on this project. So what we did is we brought in an entire team of healthcare professionals and actual citizens. So we have a citizens advisory team, which is citizens from Calgary to play the role of patients and family members. And we had them engage in very realistic scenarios that were very intentionally designed. So we had a code blue, a central line insertion, and a patient lift scenario. And they performed these scenarios. We videotaped it from a whole bunch of camera angles to capture everything that was going on. And then we analyzed those videos, doing what we've been talking about a lot today, link analysis. So we plotted where people were moving in those spaces, so the nurse and the doctor and the RT in this one scenario. And we can look at flow and usage in that one scenario in this mock-up room before it's actually built. One of the things that we learned, and then we plotted the bumps, sorry. So the bumps are the location where something collided with something. So one of the things that we learned was that there was a pinch point between this articulating arm and the sink where there was a kind of a clustering of bumps in the bottom left there. So one of the recommendations, or I guess the challenge here was it was difficult to get to the head of the bed and bring equipment to the head of the bed when needed. So we looked at the link analysis for all the other scenarios in that same space, and what we found was there was a space that wasn't really being used, and we recommended moving the sink to here to minimize that pinch point. What the architects did was they rejigged it, came up with an even better idea, and they moved it all the way to the other side of the room. So then what we did when we went back to do those simulations, what we found was that it completely eliminated all of those bumps when getting around the articulating arm. So it kind of fixed that one problem. We also looked at visibility of the patient. In one of the mock-ups, we can see on the left, we had all these windows for good visibility of the patient. We know that's important. But for privacy reasons, when they built it at the South Health campus, they put in these blinds. And with the blinds, you have the column. And with the column, what you can't see in this picture behind this column is there's 3 healthcare professionals working in that space, and you can't see them from this observation area. So there's sort of a blind spot. And similar to a blind spot on your car, we just looked at what was being blocked from the different seats in that observation area, and then moved that column to minimize the visual obstruction to the patient to improve the visibility. So in terms of cost benefit, the capital team did do a cost benefit analysis, and in addition to hopefully providing safer care and more efficient care, there was actually a significant cost savings as well. The simulations, those 4 simulations, cost $258,000, but ended up having a net savings of $1.7 million. And there was a question about that earlier, and that had to do with just the cost of, it's a lot cheaper to change things up front instead of after it's built through those change requisitions. So then we went into the detailed design when they were starting to go to an RFP for the medical devices and equipment that was going to furnish these spaces. And what we did as part of the RFP process, we were evaluating the automated dispensing cabinets that were through the RFP process. So we had 4 shortlisted vendors that came into the space that we were evaluating. And we had the vendors configure those cabinets, fully configure them as if they were going to be implemented on a medical surgical unit. And then they came on site and provided training for a group of nurses and pharmacy technicians who would ultimately be using those cabinets. We brought that user group back the following week and ran them through usability testing, where we looked at the design of the device and the safety implications and the performance implications. And then we did what's called heuristic evaluation, where we compare the interface to known design guideline principles that we know to make things more user-friendly. So all of that information was then embedded into the RFP process so that we could purchase a more user-friendly device. And to give you an example, here's one of the scenarios that we used for the nurses. We asked the nurse, we told the nurse patient B was experiencing significant pain and wanted morphine, so we asked the nurse to go into the cabinet and retrieve that morphine. What the nurse didn't know as part of this scenario is we had actually gone in an hour before the simulation exercise and administered morphine to that patient, and that morphine was ordered for every 4 hours. So what would have to happen in this situation is the nurse needs to recognize that it was already administered, probably by a coworker, before shift change, and then consult with the physician. And we wanted to look at which of those cabinets best communicated that message to the nurses to avoid that potential overdosing of morphine. So here's how the different cabinets worked. This one had this pop-up window, and I'll blow it up for you. It says it's been less than a minimum of 4 hours. Do you still want to continue? The nurse says either yes or no. But with this other cabinet, it's in a very small font, and I'll blow that up, and this is what they have to find. It says it was last given at 8:08, and the order is for Q4H PRN, which means every 4 hours. But now it's up to the nurse to do the math and recognize that, oh, it was just administered 1 hour ago, and I need to now consult with a physician. So when we looked at performance measures, what we found was that vendor A effectively communicated that message 83% of the time, vendor B 0% of the time. In other words, none of the nurses caught it. So that has a fairly significant patient safety implication on a very small design detail. So that goes back to, I guess, some of your talk about testing the equipment. And then in the construction and operational planning, what we're doing is looking at different medication administration processes. So there's different ways that we can have nurses retrieve their medications, whether it's all at once at the beginning of the shift, go back periodically throughout the shift. And so what we did for this was we process mapped it out, did tabletop simulations where we looked at using actual Lego pieces, moving them around where they would be, what they would need. And then we brought in teams of nurses. They had one unit that's finished ahead of schedule intentionally so that we could run these simulations to help inform, I guess, process-related issues for the rest of the hospital. This is still work in progress, so we don't have any results on this part to share with you, but it's work being done. So in summary, I think that human factors is applicable to many of the design stages. I've given a few different examples of what that might look like. There's obviously lots of different ways that could be done, but I'll wrap it up with that. Thank you very much.
Good afternoon, everyone. I know it's almost an hour after lunch, and probably I'm not the last one before the break, so it's a great thing, you know. But I won't take anything away from my friend. What I want to spend some time is, you've heard the virtual story. There's different means, you know. I wanted to give some overarching philosophy. This is something 6 or 7 years ago when we started this journey. You know, we had some of the same dialogue we had in the morning in terms of spending 8 more months in the design process. Today, my CFO means there was a time when every single day he would knock my office and saying, one day costs this many dollars. And we are talking about 8 more months, you know. But today I can't find him because, you know, we've seen some of the benefits of getting it right the first time. I want to start over here. One of the philosophies were, we've heard this long, you know, it shouldn't take a good nurse or a good clinician to have a good day, to have good outcomes. A clinician can have an average day, but the outcomes from a patient perspective need to be consistent and reliable. And what gets us over there is good processes. You know, and that was one of the biggest emphasis for us. How do we design processes which give reliable outcome? You don't need good people, you need good people, you know, but now think about it, you empower them with good processes. How many of you have walked into a beautiful, aesthetically beautiful facility, but when you ask the operations people on a day-to-day basis, it's a crisis management every day. And then we talk about environment, you know, so one of the biggest opportunity, and I think John spoke about it, even before we put pencil to paper, we mapped, we kind of got a state of the union for over 165 of our processes. Because that was one big opportunity, facility design, which we thought was to change our culture, to change our processes. And before we moved into this facility, there were 90+ processes which were fundamentally changed. Med administration, you know, a lot of times, very good dialogue, you know. Think about it. From a med administration, what is good for nursing is not good for pharmacy, and what is good for pharmacy is not good for nursing. We forget the patient. We forget what is right from a patient care perspective. And really the emphasis, you know, today, like there was a slide in the morning you saw, to look at facility design and process from a patient perspective. Means that in healthcare, we are notorious to kind of have, even today in this room, I can guarantee, we can define how many customers do we have. Clinician thinks they are the customer, the facility needs to be designed around them. You know, if you talk to a physician, they think they are the customer. You know, but a lot of times we forget the patient. And so real emphasis over here, if what you've seen is how do I design processes? There are multiple tools. Tools are means to an end. You know, the question is, do you need outcomes? How do you design? Because environment is a latent factor. Environment enables or disables in some instances, you know, good outcomes. So, this is not a test. You've seen the Swiss model now probably the 5th time, you know. One of the things, you know, I use this slide is, we did the current state. There's a lot of study about how much a clinician walks. We were going from a semi-private facility to a private facility 3 times. The key over here is this is time spent away from the bedside. How do you design an environment? If you think about from enabling it, how do you design an environment which takes the clinician by the bedside? There's a lot of anecdotal, evidence-based, where the more time the clinician spends by the bedside, clinical outcomes improve, patient satisfaction improves, and more importantly, staff satisfaction improves. And how do you take those barriers away? Going back, a good nurse can have an average day. But if I have good processes, good environment, how can I ensure my outcomes are reliable and consistent? One of the things, and I'm not going to go through the whole process, we used whatever tools we use, lean was a good structure for us. That is not the only way to go about. It gave us, a framework. It gave us a design philosophy for us. Really, how do you get the staff involved? How do you give them a framework when you're working with your architects, as you're working with your planners, to kind of give them a point of reference, which becomes from a thinking perspective. And that gave us one of the advantages we had of being a process improvement culture was our staff was able to relate to it. It gave us the tools to kind of saying, this is an opportunity, to redesign. Let's not take our dirty laundry from an old facility into a new place. And that's where the empowerment, you ask these people, they'll tell you what the answer is. The question is, how do you empower them? And how do you provide a structure to give you a solution, or a process which they own and they are proud about? Because if this facility is only as good as how an average nurse on the floor can operationalize it. The best of environment is only good, if the staff and the clinicians who provide care on a day-to-day basis, they don't buy in. Because you could have a beautiful facility and it could work exactly the other way in terms of how you intended to design it. These are some, I'm not going to go through it, but one of the biggest things, how do you eliminate waste? I'll give an example, the tube systems we saw. The process around the tubes, it was about, are we going to batch the labs when they are drawn? Are you going to kind of do continuous flow? And one way for us, which was important from a good turnaround of labs, is the importance of not batching it. Today, in a lot of our other facilities, still we batch those processes. When a phlebotomist in the morning goes out, draws the blood, we still batch them, in some facilities. Over here, we had the opportunity to kind of saying, through technology or through structure, is there a way I can get continuous flow? Now, if you think about all the implications, if I get timely turnaround time, I could get early discharges, I could better manage capacity, I could better manage my ED holes, but there is no one factor or variable which impacts. It's like, how do I put pieces together which enables those outcomes? We looked at it, means these were some examples in terms of how we were able to get some lean thinking, at the master planning phase. We moved on, from master planning to schematic at an individual level, in terms of at a department level. You saw a lot of work, being shared, and you got the opportunity to kind of walk the units. Again, a lot of emphasis, what we wanted, means, as I said, there were 90 processes. We had to work through them even before we moved here, as many as we could. Like NICU is a great example. That's a big change in clinical practice. Moving from a nursery model to a private room model. There's a lot of evidence, but that private room model will only work as good as how you design the processes, which kind of support it. And that's one of the many examples, but which we, have kind of looked at. And that's pretty much what I had. I wanted to be brief. I know you've heard the virtual story enough, but I'm sure there'll be questions and we can, later on answer those.
Well, I guess this makes me the last speaker after lunch and before the break. And as you know, I've only got 10 minutes, so I'm going to very, very quickly share with you a couple things that I will not be talking about today. Some of you are aware that I've spent a good bit of my career focusing on the design of diagnostic and treatment environments, which I like to define more briefly than just radiology. I define it as anything that ends with ology, which led me a couple of years ago to rename surgery to surgology so that it would fit into my own definition of D&T. And so if I was going to be talking about surgery and imaging today, I would tell you that not only do these environments have the challenges of all other environments in the healthcare setting, such as hospital-acquired infections and medication errors that we heard about earlier, but compounded with that are some of the unique safety challenges, such as surgical and anesthesia complications, wrong patient or wrong site surgeries, our radiation exposure with things like surgology and the convergence of surgery and imaging, actually new design safety challenges that we never had before, MRI safety, and certainly what's very much a part of the entire healthcare environment, our communications errors. If I was going to talk about radiation safety, I would probably tell you three things. One is that our equipment, our radiation emitting equipment, is getting safer. Year by year it's getting safer, less radiation leakage. I would also tell you that what is determined to be an allowable or permissible level of radiation exposure has gotten down. So when we put those two things together, equipment's getting safer, therefore we're going to need more and more shielding as time goes by, because what was considered to be safe 10 years ago is not considered to be safe now. It's kind of ironic. What I would also tell you is that there's a growing concern, as I'm sure many of you are aware, of lifetime accumulation of radiation exposure, particularly for kids. So we're already seeing, and we're going to continue to see, alternatives to radiation emitting technologies, whether it be ultrasound or MRI. So, for example, to solve the safety issue of radiation exposure, we're going to be seeing more use of MRI, which then creates its own safety issues. And I'm sure you're all aware of the landmark incident in 2001 where a 6-year-old child was killed in an MRI scanner post-surgically because somebody unintentionally, inappropriately brought a non-MRI safe oxygen tank into the room. You're probably also aware that the American College of Radiology shortly after that created a whole series of safety guidelines, which are not mandated, they're not code, they're not required, they're guidelines just like the facility guidelines. They deal mostly with operational issues, but they do deal with some significant facility issues. You may or may not be aware that those guidelines are fairly widely not understood, and they're fairly widely not complied to. So as I travel around the country, around the world, I see many, many projects designed which do not follow those guidelines. You may or may not be aware that as we see further integration of surgery and imaging, particularly intraoperative MRI or MRI-guided surgery, that the criteria in those safety guidelines, which are designed for diagnostic MRI, do not necessarily apply. So a couple interesting conundrums. I'd also tell you that MRI safety is one of the top 10 considerations of the C-suite of issues that keep them up at night about safety risks. I know we have a lot of ergonomists, human factors specialists, perhaps some interior designers, and everyone here is related one way or another to safety issues. How many of us think about, for example, the design of a radiology reading room as a safety challenge? Okay, it's always 1, 2 hands. Not because I'm worried about carpal tunnel, that's a reality. But if you think about it, the reason we spend millions of dollars on imaging equipment is not for the equipment, it's for what happens in this room. It's for the sole purpose of data mining gathering information by which radiologists can make a diagnostic opinion to have a significant impact on a patient's course of treatment. And the reading room is one area that is significantly under-designed, not designed, or not understood how to be designed, particularly as we're moving into a soft copy world. And I would just sort of keep that in the back of your minds as we think about slips and falls, medication errors, other things, that some of these communication centers, the ability for specialists to really focus on what they're doing in a very rapid and demanding way, become, in my opinion, some of the core areas of sort of the beginning of safety design. So now that I've gotten all that out of the way for setting context, I can begin to talk about what I was asked to come here and talk about, which are some of the tools that we use architecturally for a safe mindset or safe designing for safe environments. Several years ago, I was speaking at the American College of Surgeons, and I heard one of the many presentations, I'm sure that you've heard, already referred to earlier today, about the use of aviation safety checklists in the surgical and anesthesia environment to improve safety. At that moment, it occurred to me that we as architects really need our own flight-ready checklists. Not to turn design into a checklist kind of process, but to simply put in front of us, and to talk about Ellen's question about at what point of design do we really need to begin this quest for safety, to put in front of us on one piece of paper or electronic media what are the most important things that we need to fight for in terms of safety design. And I would suggest that if we try to do everything in any given design project, we'll at best do some of them kind of in a mediocre manner. I believe for each project, for each client, for each budget, and for each site, we need to, as we create our visions with our clients, figure out which of these many things come to the top of the list. So I'm sure you can't read some of the small print, but this begins to codify or summarize some of the issues of which the built environment has an impact on medication errors, on slips and falls, patient safety, staff safety, etc., arrayed with other things that are not necessarily safety related. And we use this to just sort of keep focused during the design process while we're being challenged by budget, schedule, and everything else, to keep in our forefront of our mind those things we want to fight for. And I think that design process and the tools to try to go back and keep focused on these are some of the most important drivers of whether we in fact will be successful. Now, right about this time, we received a couple grants, one from the AIA College of Fellows, the other from the Boston Society of Architects, to begin to look at what I like to term the intersection of evidence-based design and sustainability. And what led us to this research study is we began to think about, as sustainability was becoming a really significant driver for healthcare design, actually ahead of evidence-based design, we began to think that perhaps these two drivers were being addressed separately from each other. And we felt it was very important that they needed to be, among other factors, looked at in a much more comprehensive way. And we began to think, is it possible that as we design a campus or a building to conserve water, are we perhaps unintentionally creating disincentives for hand washing? As we use the best HEPA filtration systems in the surgical theaters, are we perhaps specifying an air handling system that is not the most environmentally efficient? As we're looking for natural ventilation in more and more areas of the healthcare environment, are we perhaps looking at that in absence of issues of infection control, et cetera, et cetera, et cetera? And we like to refer to this whole study as environmentally integrated, evidence-informed outcomes, or what we just refer to as EIEIO. And that's actually become, I've written a couple articles on the extreme importance of EIEIO in health facility design. So as we were developing our flight-ready checklist for evidence-based design and safety best practices, and we were simultaneously trying to integrate evidence-based design and sustainability, one of my colleagues came up to me and said, well, why are we creating this focused, narrow, evidence-based design checklist when we're spending a lot of time and effort researching as broad an area of factors, including sustainability? So, of course, the logical thing was to design another checklist for the best practices of sustainable design. What we realized is one checklist is a very, very useful and efficient tool. Two checklists are really hard to use and don't work too well. So we at least took a first pass at what we think flowed to the top of the list of the most important areas in both of these sort of categories, and then began to look at how do they perhaps support each other or perhaps conflict with each other. The logical thing to do, of course, was then to create a matrix. And as you look along the top axis, the x-axis represents all those headings of evidence-based design and safety-related best practices. The vertical axis are the same categories as sustainability. We have approximately 3,482 intersections. And when we print this in the smallest legible font, it's about 3 feet by 4 feet on the wall. So it becomes something also pretty hard to get your arms around, literally. But it became the first space, the first phase of us beginning to define our roadmap for research. We felt that what we want to be doing for the next decade or so is really looking at these intersections of evidence-based design and sustainability and develop tools to better focus on them. The idea was not to fill out each and every one of these intersections, because that would take us probably longer than the design of a building, which takes long enough, but to begin to prioritize which of these intersections either are inherently mutually supportive, which would have a green dot, if it's very mutually supportive, a green outline dot if slightly, or perhaps more importantly, or equally importantly, which ones seem to have an inherent conflict, like the ones I mentioned a few moments ago. So for example, if we look at high-performance facade design and look at that in the context of bringing daylight into the interiors of our spaces, they seem to be pretty mutually supportive. But if we look at, for example, right-sized air handling requirements and operable windows, both are very important to us. They seem to create this dynamic tension. Our goal is then to create a research-focused deep dive to see if we can turn that red dot into a green dot, see if we can come up with some design solution that actually becomes a win-win, or at least is not done excluding the other. And so to sort of kick this off, and I don't know where I am in time, 2 minutes, good, this is a 2-minute video. Wow, how did that happen? We began to create a series of what we call 1 by 120s. And a 1 by 120 is simply a 2-minute video type presentation on any topic. And this one in particular is about our views on the flight ready checklist. And hopefully it actually will describe what I've tried to say in a clearer way than just sort of putting a bunch of words on the screen. Let's go right back there. New version of PowerPoint.
Ground control to Major Tom. Ground control to Major Tom.
Leaders in medicine have borrowed tools from the aviation industry to reduce medical errors and to improve clinical outcomes. For example, in many operating rooms, a flight-ready checklist, modified for medical use instead of aviation, is used to verify that the correct procedure is being performed in the correct location of the correct patient by the correct team. This has had a profound impact on reducing wrong site and wrong patient surgeries in recent years. At Anshin & Allen, we desire to embed our projects with an abundance of best practices and evidence-based knowledge. To that end, we have devised our own flight-ready checklist of best practices to be used as a tool, similar to that used in the operating room, to assure we are designing the best possible projects with the best knowledge to achieve the best outcomes. In surgery, the surgical team takes a timeout before beginning their intervention to assure that everyone is working together towards a common goal. Similarly, the design team should take a timeout before beginning design to assure we have strong foundational ideas and clear concept diagrams supporting our design. The flight-ready checklist can be used at the earliest moments preceding design and continuously as design progresses to assist us in first identifying the best practices we wish to integrate into a particular project, and then as a yardstick to measure our success in applying these practices. Patterned after Derek Parker's landmark article, The Business Case for Better Buildings, our Flight Ready checklist considers the range of best practice attributes we would generally want to incorporate into our designs, such as patient and staff experience and satisfaction, patient and staff safety, reduced medical errors, reduced infection rates, operational efficiency, life cycle flexibility, financial performance, as well as specific concepts such as acuity adaptable patient rooms, handed rooms, and the integrated interventional platform. The Flight Ready checklist is designed to be used with other Anshin and Allen research tools, such as the Fable Hospital Matrix, our pivot table database of best practice articles, flashcards, and our library services. Those tools are available to enrich our knowledge regarding various aspects of best practices so that we may better integrate them into our project work. If you have questions about the Flight Ready checklist or other research initiatives at Anshin & Allen, speak with our core research team.
This is ground control to Major Tom.
What I'd like to add to this, obviously this is a very simple tool it's not intended to be anything other than a tool. And it's not created to change the design process, it's created to communicate. In this case, primarily communication within our staff. The two things I want to add is this was all done back in the days when we were called Anshin & Allen, we're now called Stantec, in case there's any confusion. But the other thing I want to kind of close with is I think it was Skip that asked the question about the guidelines. Should it be broader than just patient safety? Should it include issues of sustainability and other things? I feel very, very strongly that anything we do regarding evidence-based design or safety needs to be as broadly based because the health and care environments that we're designing have very few things that are isolated. And when we test either in research or in design one isolated element, it may prove one conclusion, but when we put it back into the complex medical environment, there are so many other variables that will have unintended consequences. And one key example, when I showed the research of evidence, the EIEIO study we did, one of our findings, which was very surprising to us, is among other things, we did chemical analysis of all of the common building materials used in the construction of a hospital. We found that and when we evaluated them in terms of not just human health and safety, but environmental health and safety. We found first off that less than 10% of the common materials used in any healthcare building design construction met the criteria that we had set for both human and environmental safety. And specifically, we ended up testing about a dozen different types of paint. We got a huge range of acceptable, unacceptable criteria for those paints based on the criteria established for human safety and environmental safety. And I just wanted to see if anyone might guess. What was it about the 5 or 6 paint samples that failed that they had in common? Anybody? If you know the answer, don't guess.
Oil-based?
Oil-based? Nope. VOCs? Nope. Because we're out of time, I'll give you the answer. Those paints that all failed the criteria had one thing in common, and that is that they included infection control additives, antimicrobial additives. So had we studied them purely for human health, they probably would have all got A+ ratings on their success. Unfortunately, what we discovered, and it was actually obvious when we went back to the definition of antimicrobial, i.e. killing agent, is that they all contained heavy metals, which whether they were effective or not in containing the spread of infection, which the jury's out on that, they were clearly made up of elements that we did not want to be producing, and we certainly did not want to be leaching into the environment. That's one of many, many examples of why I think as we do these very, very focused studies, which are absolutely important and essential to do, we step back to the forest and not just the trees and look at the dozens, if not hundreds, of unintentional consequences of every design decision we make. This may be a good segue into the break, and I think we'll come back and talk about this in more detail.